This conference will now be recorded.
Okay, all righty. So this first case is a nice case. So this patient had no previous imaging, was in her 70s, and presented with shortness of breath to the emergency department. And you look on the radiograph, you can see that the central pulmonary arteries are a little big. The interlobar in particular is quite large. And there's relative lucency here in the right upper lobe. You might wonder about emphysema. The vessels are small or something else going on there. And then on the lateral view, you can see that the right ventricle, the retrosternal space is a little bit full, so that I think the main pulmonary segment is big, and you can clearly see that the branch pulmonary arteries are big. So findings pointing to pulmonary hypertension. They were worried about acute PE at the time, so she got a CT scan, and what we see is clot in the pulmonary arteries, but you'll notice that it's not your typical acute PE. It's along the walls, um, and there's irregularity to it, and there's some webs here. So I think most of this is not acute, but rather chronic clot in her lungs. Her RV is dilated a little bit as well. And if we look at the lung parenchyma, there's a nice example of mosaic attenuation. Now, she does have some emphysema, but it's fairly mild, and you'll notice the vessels in the right upper lobe are small with what we saw in the radiograph here. So there are these areas of decreased attenuation, see anteriorly there in the left upper lobe, and then even down in the lower lobes a little bit in the middle lobe. You can see there's just a subtle areas of decreased attenuation. So we suggested this was CTEPH, and she underwent an echocardiogram, which confirmed right ventricular enlargement and some uh, high pressures. She had a right heart catheterization, which confirmed the pulmonary hypertension. And then as part of her evaluation, she also had this VQ scan. So we got the ventilation at the top, and you can see her ventilation isn't great, but there's these some large defect, particularly in that right upper lobe as well. But there's some subtle peripheral defects in the left lung as well. So a nice case of CTEPH presenting presenting with shortness of breath, with no previous imaging, no history of PE. I thought the radiograph was quite nice for pulmonary hypertension. Um, I'm not a big fan of the so-called Westermarck sign, or with the hypolucency from acute PE. It's usually you see it takes time to remodel. I suspect it's more from the chronic PE, but that was kind of a fun case. All right, this
Hey Jeff,
next case,
where do your patients go for thrombo and arterectomy, or do they get done in Madison?
we don't do them here. We have traditionally sent them to San Diego, uh, and we send our angioplasties usually to Northwestern.
Okay.
Yeah, but I know you guys have a program now, and our pulmonary hypertension expert, I think he's aware of that as well. So I think Duke's now an option for them as well. So we'll try to send more your way.
No, I was just
Yeah,
curious.
yeah, we've
Get
seen
in.
about 20 CTEPs a year now.
Yeah.
We're starting to catch more of them. So I think we're getting more regional referrals. We get a lot of pulmonary hypertension referrals. But that was a fun one because I haven't had too many de novo ones. My colleague Mark shared this case with me. It's just this patient had presented with shortness of breath and swollen lower extremities. And this is one of the prettiest cases of calcific constrictive pericarditis I've seen. Also, one of the more exuberant ones. I don't think I've seen one this bad in a long time. And you can see there's even milk of calcium, presumably in the pericardial space. And you see the dilated IVC. They're not huge. The SVC is normal, but you can imagine this is causing quite a bit of constriction. There's ascites, presumably all related to some pleural effusions. Unfortunately, there is no radiograph because it would be really pretty to see this. But this I like this one in particular because you can see the separation of the two layers with this milk of calcium in there. No risk factors for TB, no under known connective tissue disease. So the thought is it may be from a previous episode of viral pericarditis. Patient had a flu-like illness a while back, but that's the only thing that anyone's been able to work out. I don't know if you've ever seen anything this extensive calcification wise.
Yeah, that's exuberant.
Yeah, it's
So,
pretty nice.
so Jeff, the
They make the point about the calcification in pericarditis sparing the left ventricular apex. So
Really?
yeah, it's supposed to spare
Well,
that.
look at that.
Whereas calcification from a calcified infarct, its favorite location is the apex. And your case
Right.
seems to meet those criteria. It spares the apex of the LV.
What
So
is
when
the
you're looking
thought
at
process of
calcification
why
of a
that
brain cone and
happens?
trying to decide is it myocardial or pericardial, that location is helpful.
Yeah. And it's interesting, it's kind of stops right here as well. You see, not along the posterior aspect of the left atrium, just where the pericardium is. Yeah, I don't know why it does that. That's very interesting.
David, what's the theory behind that?
The rationalization is that the apex is moving so vigorously it can't calcify. It's attributed to the motion of the apex. Who knows?
Interesting.
And the left pleural
Yeah, if that were all
effusion
mild.
is separate from that, but we don't know what the left pleural effusion is due to.
All right. So this patient is a younger
Oh,
patient who.
Howard, hey, Howard had
Oh,
asked a question about the left pleural effusion
oh,
in that
sorry.
case. And
Oh, that was just
Howard, your sound's a bit muffled. I'm having a
yeah,
hard
they
time
also
hearing you.
had ascites too. So did they have cirrhosis from their constriction or just,
Not yet. Not yet.
okay.
It was a relatively new diagnosis. Yeah, you can see the ascites there.
So the other bit of lore that goes with pericardial disease is that it's a cause of selective left pleural effusion. Unlike heart failure, which is selective right, pericardial disease is selective left. And I've seen a number of cases of acute pericarditis, and that holds pretty commonly. Um, so you don't actually need the ascites and leaking across the diaphragm to invoke a selective left pleural effusion in the setting of pericardial disease. But maybe it is maybe it is hepatic hydrothorax for all we know, but it doesn't have to be given the pericardial disease.
Yeah. And is that because there's more usually there's some pericardium touching the left pleura, whereas the right side of the pericardium doesn't usually touch much of the pleura?
That's my rationalization, but I've not heard any cogent theories that are you know brought up for that.
Okay.
in terms of pleural fluid formation, generally speaking, it's hard to tie in pleural fluid and pericardial constriction. So I'm a skeptic.
Yeah, I don't know. This is the initial only imaging I have on this patient, so more to come. But I think doing a pericardectomy is going to be a bit tough on this one because it's pretty thick, but I'm sure they can figure it out. All right. This next patient's very interesting. I don't have any pathologic proof, but I have presumptive diagnosis. So this is a young person who came in to the emergency department short of breath with a little hemoptysis, I believe, over a short period of time, and had this CT here. And you can see there's all these central lobular, sort of somewhat larger ground glass attenuation nodules. There's some bronchial wall thickening and a pretty extensive amount, and a little bit of septal thickening. Has no otherwise previously healthy, but works has had some pneumomediastinum, but works in a factory where exposed to a bunch of metal fumes, and I suspect this is probably metal fume fever. As far as I could tell when I looked into this further, there was everything else was negative. I mean, you could consider vasculitis something like that. But turns out the patient reported several other of his coworkers had similar uh, symptoms over a short period of time. And he does wear a mask, but he doesn't cover his nose with it. Um, so he doesn't wear his protection properly. Um, so it's can be caused by exposure to certain metal oxides, but it's sort of this vague term. But they get this systemic response, and they can get a little hemoptysis, and they can present sort of with this central lobular pattern, sometimes a little bit of edema. I presume the pneumomediastinum was just sort of a Macklin effect from a lot of coughing, but I don't know. I don't have any. I haven't seen really any cases of metal fume fever, but this seemed to fit the bill. So a presumptive diagnosis of metal fume fever in a guy who works with a lot of metals that vaporize. I think he welds a bunch of them too. So I don't know, David or
Yeah.
Howard, you may have seen this.
No, I've not seen that, but presumably it's a form of acute lung injury.
Hmm.
Whether, if you did a biopsy, what would one see? You might see typical findings of DAD. Wouldn't be surprised if one saw foci of organizing pneumonia, but the pathology
Right.
is associated with acute lung injury.
It kind of reminded me of some of the vaping cases we saw that were more central lobular, that were a form of organizing pneumonia, just centered more on the airways. So
You know, this is
history is
upper,
very important.
yeah, this is upper lung predominant, which goes with most inhalational diseases. But
Absolutely.
the vaping cases you guys have shown in the past, those have often been low, mid and lower lung predominant, right?
Just
Um,
mostly diffuse.
The, the nodules usually were more mid to upper when there were discrete central lobular nodules like this.
Yeah.
yeah,
But eventually,
yeah, it
it
seems
looked to me as if the diffuse lung disease ended up being worse than the bases in many cases. Am I just remembering incorrectly, or was that the fact?
I mean, most of the cases look like your typical organizing pneumonia, and they were kind of wherever they wanted to be, but um,
Okay.
looked more like COVID. But the ones that were the more central lobular patterns seemed to be, like as Travis said, they were more mid upper lung. They looked, I think originally we referred to it as like an HP like, but it turns out it's really OP,
Got it.
Yeah,
centered on the airway.
David, you're right. The more traditional run-of-the-mill organized pneumonia or acute lung injury (DAD) cases were lower lung or diffuse.
Okay, and then this last case, I think you will all like this. I haven't seen a good one of these in a while. This is a 30-year-old who got a CT for a mass, and I don't have the radiograph because it didn't come with the patient, which seems to be the case a lot of times. But young person, and you can see on the right already we see some big bronchial arteries, and we can follow them down here on the right. And then here's this mass, but you'll notice there's a lot of vascularity around it, and it's very low attenuation. And then all of this vessels being recruited off the inferior phrenic, which is pretty big. Um, but I don't see a single large um, vessel. So I showed that sequestration last week, well, that the systemic arterial supply last week. So this turns out this is like a chronic abscess here. So this is a pseudo sequestration, is what I would call this. And I think there was, and David can elaborate on this because I know we've had this conversation many times about sequestrations being congenital, and most of us, I think, disagree. I've seen them on, I mean, being acquired, the intralobar type, and I disagree because I saw plenty on prenatal ultrasound as a resident, where you could see the big artery coming off, and you don't get neovascularity with an artery the size of a carotid artery just coming off something. But this is what I think sometimes gets called a sequestration, but is really a pseudo sequestration. It's sort of an area of chronic inflammation that is hyperemic and has parasitized the bronchial circulation and all these sort of vessels near the diaphragm and adjacent mediastinum in there around this abscess here. I don't know what the bug was. It might even be tuberculosis. Who knows? But I think, would you all agree this is a pseudo sequestration?
Yeah,
Yeah.
this is
Or some
beautiful case.
Yeah,
Was the
let me
patient's
make a.
condition subacute or is somewhat chronic rather than an
It
acute respiratory illness?
is not an acute presentation at all. This has been going on for some time.
Mm.
So, Jeff, could you give us an angiogram of this case? That would be delightful. Oh, look at that.
Yeah, there you go.
Oh, beautiful.
So a pseudo sequestration. Yeah, so I think it's not because and yes, there's a big uh, inferior phrenic artery there, but you've also got the big bronchioles coming into, and it's just all and coming off the intercostals. So
You always wonder, or I always wonder in these cases, because it's usually in the medial right lower lobe like this, or posterior basal segment. Like, did they aspirate something, and there's like some little foreign body that's the nidus for all of
right,
this?
yeah,
Yep.
Yeah, that's a really good
you
case.
do wonder, yeah, yeah, cool. Alrighty, that is what I have for this week. So who would like to go next?
I
David
can
or
show
Howard?
my case for
All
discussion.
right. You should have control now. Yes, and we see your screen.
Okay, so this is how this case came to my attention. The patient was sent here. Well, I'll give you a bit of history, but this is how it happened. The patient apparently had this cystic lung disease discovered during a CTPA, which demonstrated pulmonary embolism. So the patient was not known to have cystic lung disease prior to that time and was apparently healthy. So the patient was referred directly from the outside to one of our thoracic surgeons for a surgical lung biopsy. Wasn't otherwise discussed at an ILD conference or anything like that, and just went for a surgical lung biopsy. And my pathology colleague said, "Oh, I've got this nice case of PLCH, but there's some kind of odd things about it." So let me actually go back to show you the pathology report initially. Oh, I should mention 40-pack year history of smoking and still a current smoker. So we have, under the microscope, of course, smoking-related changes, pigmented macrophages, smokers' macrophages. Emphysema is easily identifiable with occasional subpleural enlarged spaces bordering on bully. Interesting description. Funny about lymphangiomyomatosis, because part of the outside note that I was able to read mentioned that, but this is a male, and the person's not known to have tuberous sclerosis. A few small collections of histiocytes, positive for S100, CD1A, consistent with Langerhans cells. So I'm thinking that no surprise that we have findings consistent with what one sees in a smoker. Oh, notice that other comment over here. Let me put that back up. Review of the imaging by a dedicated chest radiologist may be helpful. So let's take a look at the cysts. So particularly for trainees, I'll describe these: multifocal, multilobar, variable in size. The distribution, most of them are in the lower lung zones, and they're large in the lower lung zones, which is not the distribution for PLCH. Also, if you look at a lot of these cysts, they have thin walls, but they are large, they're very rounded, whereas the cysts of PLCH, chronic PLCH, are typically very irregularly shaped cysts, quite unlike these. The other thing to notice about this, and I'll show you a couple places where one can see there are septations within the cysts. So maybe we started with individual cysts that sort of gathered together and became larger and multi-septated, and you can see that there too. You'll also notice in quite a few locations that vessels traverse quite easily. In multiple locations, completely traverse some of these cysts. Of course, some of them are around the cysts and not pushed apart, but some of them clearly go right through and traverse these cystic spaces. And that is, I think, a very helpful feature. So septated, a lot of them, and the vessels going through there. So my reply was, these cysts are not those of PLCH. And by virtue of what I see and have described, two things come to my mind. First, Berthold-Dubé, and the second would be the cysts that may be consequent on the parenchymal deposition of immunoglobulin light chains or amyloid. What do you guys think about this case sort of in general? Any other
I
thoughts?
like the the so-called radiologic LIP, or like you said, the protein deposition case. I've Berthold-Dubé, usually they're a little more elongated and so-called floppy, and I've not seen that many cysts with Berthold-Dubé. Uh, I think it's in the differential, but they're not the most typical ones. And I absolutely agree they're not the cysts of PLCH. And I wonder if they just saw you can see some PLCH lesions in the lungs of smokers but it doesn't
Oh,
represent
sure.
the true disease. But so I don't know if they saw like tons and tons of LCH lesions or if they just saw a few scattered little nodules of LCH
Yeah,
that
notice
just
here
happen to
that
be
they
there.
say few small collections of
Yeah,
Langerhans.
I would.
Few small
Yeah, I
collections.
would bundle that with all the smoking related changes, but I suspect, you know, this is probably autoimmune disease, highly worried about Sjogren's syndrome or something along that spectrum.
Yeah, yeah. Do you find the notion of the vessels traversing the periphery of cysts or right through the middle of cysts or right through the middle of septated, complicated cysts like that, septated cysts helpful? Because I do in terms of a differential.
Absolutely.
Yeah,
Absolutely.
can see that in
That's
quite a
again, I
few
see that with
patients
Sjogren's
here.
syndrome and autoimmune disease.
Yeah. So this is kind of interesting because they've done this lung biopsy and smoker's lung has been diagnosed, of course. I think the only thing to do is to go back from the clinical and historical point of view and ask the patient questions. So you can ask the patient about a family history of cystic lung disease. You can you can examine the patient to look for skin lesions that go along with Burtog-Debay. You can ask about pneumothoraces in the family. And then, of course, you can ask about dry mouth, dry eyes for Sjogren's disease. And then just make sure the patient doesn't have a yet undiagnosed lymphoproliferative disorder, like I'm not sure what, sort of an indolent kind of lymphoma or multiple myeloma or something that could be associated with the deposition of light chains. And then also evaluate renal function, because in the differential is light chain deposition disease. So history and physical will be the most important next step. The lung biopsy didn't really make the diagnosis, right? Oh,
Yeah, I mean, we don't really biopsy cystic lung disease
right.
anymore. It's just,
Yeah.
I mean, there's genetic testing for
Great.
most of the things. The history
Yeah.
usually answers the other question.
Yeah. Exactly. So, kind of a lesson what happens sometimes if you sort of bypass the usual consultation or discussion or an MDD and just go straight to a surgical lung biopsy because the patient was referred for that. Yeah. Yeah. So much I'm going to have any follow up particularly, but I'll check the patient's medical record after a couple of weeks or months have gone by just to see what has happened. Perhaps I may not be able to find out. But the pathologist did talk to the surgeon after our discussion. But I like this
I don't know,
concept, right?
Ed, I
Of,
don't know about your institution, Howard, but one of our rheumatologists does lip biopsies to sample the minor salivary glands, which is like the
ooh,
now like the reference standard for Sjogren's syndrome. So even if the autoantibodies aren't a slam dunk, but there's something suggestive of it, sometimes they will do that if it's going to change their management.
yeah, yeah, it's kind of back to the drawing board, history and physical. Start with that. Yeah, yeah, it's a nice case. Huh? All right, that's my
All
consult
right,
and
very
interesting
nice
case of
case.
the week.
All right. David, any cases?
I do have some cases.
All right.
Jeff, I think I'll have some by the time he's done presenting too.
Oh, great. Okay.
Can we see a chest röntgenogram?
Yep.
Okay, I wanted to show you guys this case because this is a fairly unusual manifestation of asbestos exposure, and that is diffuse pleural thickening. And it's always confusing because diffuse pleural thickening has so many other causes, including, as this person has had, cardiac surgery. So, but we do have diffuse pleural thickening here that blunts costophrenic angles, unlike plaque, which spares costophrenic angles. This person has plaque as well. Here's a calcified en face plaque up here. Here is diaphragmatic plaque on the right and diaphragmatic plaque on the left. So we have pleural plaque and we have diffuse pleural thickening. So that's the blending of the costophrenic angles. Unlike plaque, diffuse pleural thickening can cause lung restriction. So it's actually compensable, whereas pleural plaque by itself most state agencies won't compensate a worker for having pleural plaque. Diffuse pleural thickening or asbestosis do get compensation though. And then I'm presuming that this is plaque calcification down here. It's got that look of plaque rather than diffuse pleural thickening kind of calcification, which tends to be more irregular and variable in thickness. This is pretty discrete. And I think that fits well for ordinary plaque. So this person has plaque and diffuse pleural thickening, has low lung volume, partly because of restriction from diffuse
Yeah.
pleural thickening.
And
Okay,
the
so
interlobar fissures, David, the interlobar fissures may be extensively involved, or are we
yes,
just
but
seeing,
yeah,
or what are
so
we
this
seeing? What
this
do we see on
component going up here that's tracking fissure, yeah,
Yeah.
maybe that's part of the diffuse pleural thickening rather than plaque. Be nice to have a lateral view and be nice to have CT, but I don't have that on this case.
Yeah.
Okay, so that's an occupational case. Then I wanted to show you some catheter adventures here. So here's a case of enteric tube intended for the stomach that ends up tracking into left bronchus, crossing the carina, and ending up in a right lower lobe bronchus. So sort of a sweep of the bronchi here. So how did this occur? I believe that when the catheter went down, it initially went into the right lower lobe bronchus down here. So we see the tip of the feeding tube down here. And then they continued to push. And when they pushed, they actually forced it to buckle and to go down the other side of the carina into the left bronchus because this was jammed down here. So it does not go down into the left bronchus, decide to turn around. That would be a difficult turn, hairpin turn like that, track back and then go down to the right. It went down to the right initially and then it folded into the left as they continued to hammer it in. So that's not what I would want for my catheter placement or my enteric tube placement. And then here's one that's totally in the neck here. So anytime you see a loop of tubing that's centered over the cervical spine and has a fairly narrow radius to it, a tight radius like this, it's not outside the patient. Outside the patient, it's not going to form a tight loop like this. This is formed by the hypopharynx. So here's an enteric tube that's entirely in the neck in the hypopharynx. Um, so they're not going to find this on an abdominal radiograph. And then let's see, what's the point of this radiograph? That was unintended, so let's see if we can go on. And then here's an unusual placement of an enteric tube. This one seems to go somewhere over the clavicles in the lower neck and then go down. So this is an unusual tube placement. I don't see it coming down from the nose or the mouth. So it turns out there was a lot of work to do this. This was not done casually. So let me see if I can show you the history of this. This is the placement. So initially they put a balloon down in the esophagus and they inflated it. So there's contrast in the balloon here. And then I think they used that as a target and they stuck a needle in from the side here to get into the esophagus. And they threaded a guide wire down and eventually they were able then to get a pathway going down here, and then they threaded this tube over that. So this is interventional radiology resulting in this unusual tube placement, a tube coming in over the clavicles, but not coming down from the hypopharynx and above. So initially this person got an enteric tube in a conventional location, but it was a devious path to get there and required some intervention. Have you guys ever seen this placement before? I
Oh,
need to look up the
yeah.
history and find out why exactly they did that, but I don't have that on
Mm-mm.
tap right now.
So they
Okay.
had to pass the needle carefully through the mediastinum to get to the
I
esophagus,
think through
away
the lower neck. It's above the clavicle, so it's through the neck
from above
to get into it.
down.
I'll see if I can get you a better description of this.
No, I haven't
Okay.
seen that.
They are so bold. It
Hmm.
it shocks me. Okay. And then I want to show you this person who has pleural effusion and has an abnormal abdominal CT. As we track down, we find that there are some gas collections in the anterior chest wall, quite a bit of gas in the anterior chest wall. And this is not from any intervention down here. So this is a gas forming organism. This is clostridial infection here of the abdominal wall extending up into the chest wall. There's a lot of swelling of the tissues of the chest and abdominal wall, and there is some ascites here, something going on in the abdomen. So I need to look up the history. I'm sorry I ran out of time this morning, but big abscesses here in the chest and abdominal wall from clostridial infection. So this case came up around the same time that we had a bronchopleural fistula case last week or the week before, and I showed that last week. And every time I show a bronchopleural fistula with a gas collection in a as part of an empyema, people say, well, that could be a gas forming organism. So this is a case where you do have a gas forming organism that is causing the black stuff, the gas, but in the setting of bronchopleural fistula and empyema, it's almost never a gas forming organism. It's usually bronchopleural fistula. There's a hole in the pleura, or it's some intervention with a needle or a tube that has led to the gas collection. So this case, we actually do have a gas forming organism, but that does not apply in any empyema that I've ever seen. People bring that up because of thinking about clostridial infections as a cause of gas in soft tissues. That does not apply in the empyema situation. Okay, guys, that's it.
All right.
Good.
Lots of tube misadventures and adventures. All right, Travis, you ready?
Yep.
All right.
I can start with some misadventures of a different variety here. Do you guys see a radiograph?
Not yet.
Oh, we apologize, but we are experiencing difficulties with video conference and are unable to share your screen. Let's try again. It's a
Let
new one.
me, yeah, I haven't seen that one. There we
How
There
go.
we
about
go.
now?
Yep, all
Yep.
good.
Okay. Um, so this is a level one trauma patient, and this is a few days into their hospitalization. They had traumatic brain injury. As you can see, they had a spinal fusion in their thoracic spine. They have pigtail catheter on the right, chest on the left. They have a bunch of right-sided rib fractures, and the rib fractures are what come into play here. So this is pre-rib fixation. This is immediately post-rib fixation. Now, this was an 8-hour plus surgery to fix these ribs. And you can see there is one screw loose here that they were aware of. But the other finding, and I will tell you, it was not seen on this radiograph, but do you guys see as I zoom in here, you know, a little bit of wavy something there.
Yeah, I can see that now.
Doesn't look like, it doesn't look like a retained sponge. It's pretty, it's not very dense, but there's
Yep.
something there. And on this one, a couple days later, you can see it's a little bit, you know, now that the ribs have moved out of the way, it's there. Um, on this radiograph, it's still there. And it eventually then this is only over the course of a couple days that the possibility of this being some sort of retained object was raised, and the surgeon actually suspected what this was. Got a CT, and you'll see that it sure as heck, you know, it's just kind of wadded up in the pectoralis muscle and anterior to the ribs here. So this is a type of surgical material, and it's nearly invisible. And I'm curious if any of you have seen this before. This
No.
is it's called quick clot,
No.
and And I can show you a picture. Do you guys see this web browser?
Yeah.
Yeah.
So, and so this is what it is, and it comes as this one way it's distributed like this. This is basically like 3 or 4 yards long, and it's the Z fold, so it folds. And I think this is the only radiopaque marker on it.
Mm.
And what happens in this case is that the counts were correct because they had opened one of these, but what happened was it was cut, and so one became two, and part of this was not recognized that it was left behind. And so, no real harm here. They were able to get this out, but this is stuff that is occasionally seen. So it's a hemostatic agent. It's true, and it's only occasionally used. And this was done by a trauma surgeon. Um, and so that is one case of quick clot. And I've shown this to people before, and I had never heard of this stuff, but this is what it looks like. And I show that because, you may remember I showed a case 6 months ago, maybe, of a pacemaker that had been placed at an outside hospital, and there had been a sponge that was left in the pacemaker pocket. Well, this patient has a dual lead pacemaker, and they had their generator upgraded, and lo and behold, looks pretty similar, doesn't it?
Yeah.
Yeah, and that's what this was. So this was another one, and man, on CT, I mean, they saw this was not recognized at first. It was just seen that there was a fluid collection around it, and they were suspecting that it was infected. But this was another same thing, the same material, this quick clot, and you know, all I can say is be on the lookout because I mean, this stuff is incredibly poorly designed from a radiographic standpoint. But I mean, that's virtually invisible there.
Doesn't
Yeah.
it disturb you, Travis? The marker and it looks a lot like a Ratex sponge.
Hmm.
You think they would make it more distinct.
Yeah. Well, and like, and here, because we've had a lot of discussion about these, and probably it's the same in your operating room. Most of the sponges that they use now have RFID, so that you can, they wave a wand over the patient afterwards and can quickly figure out if there's any signal that there's something left behind. But these are pretty sneaky.
Are they meant to be just put in place to soak up some blood and hemostatic, and then they leave it there for 20 minutes and then take it out and then
Correct.
continue?
Yeah. Yeah. It's a hemostatic agent, right? It's not meant to be, it's obviously not meant to be left behind permanently. And I don't know, you know, the exact amount of
Yeah.
time, but it's also been referred to as like trauma gauze, I think, or stuff that gets used in the battlefield or on the scene.
Okay. Quick.
But Travis, did it look like a set of sponges? Is it? I mean, was that a stack of sponges that the manufacturer's illustration had? And
No,
you
that
picked
is
up,
one single piece.
it's like a cube then.
This is why they call it a Z-fold because it unfolds into something, and you can see the
Oh, I see.
dimensions here. It's 3 inches by 4 yards.
Mhm.
And so the
So,
idea is
but
you pack the whole thing in, or do you cut a piece
well,
to?
that was part of the discussion. There are a lot of institutions that don't allow these to be cut because I think they've had similar issues in the past, and so that
Hmm.
was part of the discussion here.
I
Because
like
if nobody is aware that they're cutting it,
the black circle that says X-ray detectable. You could say
okay, I
maybe. Oh,
I had not
the
noticed that
whole
until just
thing.
good pickup, Howard. Yeah, there needs to be a big asterisk right next to that. Yeah, theoretically detectable if one's looking for it.
Ostensibly,
Yeah,
aspirationally.
ostensibly indetectable. That's a good point. I'm gonna have to go back to that image. All
I
right,
wonder if
here's
the stuff actually, when it soaks up fluid, becomes hard to see. Maybe it looks like just like gelatin or something like that. It may disappear. Um, and
It
maybe
doesn't
that's why they get
dissolve.
left
No,
behind. What?
it's not like gel foam. It's not something that dissolves, but it's I think it's just so the that little radiopaque portion is so lucent,
Hmm.
or it's just not very dense at all.
Hmm.
Yeah, I mean, I think it's just it's not designed well to be seen. You know, clearly a radiologist was not consulted in the development of this product.
Even a dedicated chest radiologist?
Yeah, right. All right, this one, yeah, I'm gonna pop this up really quick, and I'm just curious what your eyes go to first, the first abnormality. Kind of a gut reaction. What do you see first?
Opacity in the
What's
left
that?
lower lung. Well, I see
Okay.
two
The
things
left.
simultaneously, not just one. Opacity in the left lower lung and proximal left humerus.
What was the first
Yeah.
one you saw, though? I'm curious.
Probably the opacity
Yeah.
underneath part of the
Yeah.
bra, and then secondarily the humerus to start with.
Yeah, and that's the those are both the relevant findings. I think this is yeah, this is the presenting chest radiograph of this patient, and I think it's a good reminder too that like a satisfaction of search. You see something that could be a lung cancer. You know, I think the big clue here, and like I always tell residents and everybody, if somebody can't move their arm out of the way, and I'll show you the lateral because it's the same thing, they can't raise their arm, then you need to take another look and make sure the shoulder's not dislocated or you don't have some big metastatic lesion or fracture in the arm that's prohibiting its movement. And so, sure enough, on the lateral view, you can see the lung cancer in the left lower lobe and that left humerus unable to be moved. So I just thought this was a really good teaching case just because it shows, you know, the what the patient really presented with. You know, they had cough and they had the pain in their humerus. And of course,
Yeah,
this
very
did turn out to be
interesting.
a primary lung cancer. And they had, you know, just the CT, I mean, just confirms that. But and obviously stage 4 disease at the time of presentation with that humeral lesion. I don't even remember if they had additional foci of disease or not, but you know, I just thought it was such an interesting radiograph.
Yeah, very much so.
All right, and then on the theme of lung cancer, this is a question I have for you guys, just because I don't, you know, we see a lot of lung cancer, and then occasionally you see things that that surprise you. Let me see, maybe this is the best one to start with. So this patient, you know, has what looks like an adenocarcinoma in the right upper lobe and a few other ground glass opacities. This one also with a little bit of solid component. So both of these look like invasive adenocarcinomas, lipidic predominant. Um, Actually, this is the second CT they had. Let me show that first one. It was an outside one. Their primary tumor, maybe that's not. Well, I guess I don't have the primary. Anyway, there's an older CT that they had like a 7 centimeter poorly differentiated adenocarcinoma in their left upper lobe, which was actually the primary lesion that they presented with. And they went on they went on immunotherapy, and so that lesion responded. And I thought it was interesting because this is what this looks like in 2022. And then, you know, a couple studies later, that, oops, turn that off. You know, a couple studies later, you can see this lesion has shrunk basically. And same with this one. I mean, there's that one in particular. And, you know, we think of these like whatever you want to call it, multifocal adenocarcinoma or synchronous primaries or whatever, but I don't generally think about these being sensitive to therapy, you know, as in this case, but it clearly looks like it responded to whatever therapy they were showing because even on the more recent one, you know, it was still, you know, even a little bit more that these had decreased as well.
Yeah,
You guys,
What
yeah.
was
how
what
often do
was
you
the
notice
therapy?
that? What's that?
What was the therapy?
I think that they were on Pembro, but I will have to look, David. I didn't have time to pull it up. I can't remember if they were on chemo plus immunotherapy or what, but in general, I just don't think about these types of things in the setting of multifocal adenocarcinoma as usually responding to any sort of treatment, but maybe they
Do we
do and
know
I
if
just
this was
forget about it when
if
I
there
see
was
them.
Was there an EGFR mutation in this case, or do we know?
I'll have to look and see. Yeah, but I
Yeah,
can follow up and yeah, I've ran out of time looking that up, but I just thought it was interesting.
yeah, all of them are responding. Yeah, quite
Yeah,
nicely actually.
yeah, I know.
Interesting. Yeah,
The time frame was kind of unusual because this one really didn't change at first, and so I don't know. I'll have to look and see maybe if they even changed therapies, if the patient had recurrence. But like the big tumor on the left side shrank pretty quickly and was fairly responsive to whatever they were getting. But I guess just a general question, how often do you recognize these multifocal sites of disease with, not necessarily the intended target, but still improving?
yeah, I'm not sure.
Yeah, I mean with Pembro, if it's got high expression of PD-L1,
Yeah,
it would make sense if it gets smaller, or it's immune mediated. But
yeah.
can't recall seeing one.
Okay. Yeah, I'll try and find out and follow up on the actual therapy that was given. All right, and then I'll finish with this one. I thought this was interesting. Like, if you guys are, if your practices are like ours, where you have busy electrophysiology groups, oftentimes patients will get their mapping CT done the day before they go the or to the EP lab to get their ablation. This is a fairly young patient. I can't remember, maybe in their 30s, but arrhythmia, atrial fibrillation, and came in for their CT. And it's interesting because this was unexpected, and this was one of those ones that, to credit my colleague, she was very persistent in trying to get in touch with the electrophysiologist because of the finding that she saw. And so on the right side, you can see there's one right inferior pulmonary vein, and
Hmm.
then the right superior pulmonary vein obviously is draining anomalously into the superior vena cava. There's no associated sinus venosus ASD, but you can see the RV does look like there's probably some increased, over circulation and some significant shunt fraction. But, you know, to her credit, like I said, she persisted and you know, paged the, ended up paging the guy multiple times and had somebody finally get in touch with him. And they actually were still planning on going to go to the cath lab based on their analysis, thinking there was just only one right-sided pulmonary vein. And then when she told him, well, no, there's the right upper, and then they kind of aborted to reassess and regroup and figure out, you know, maybe they should treat this first. So just a nice, clinically relevant incidental discovery of this, or at least in this clinical context.
Can you go to, just for fun, go and show the frontal radiograph of the chest?
Yep,
Actually,
I can.
no, I don't think we'll really see anything. No, no, I don't think so.
No, I mean, again, it's like, do you think
Yeah,
the vessels are a little plump? I wouldn't,
no,
I wouldn't have been saying anything there.
for a shunt.
Yeah, I mean, the RVs, again, it's not really that big, but yeah, just an unexpected, and actually, and I should say too, that this patient, both the right middle and upper lobe are draining into this vein too. It's a pretty sizable left to right shunt there. So, okay, I will stop with that. Glad I was able
All
to
right.
get a few
It's funny
loaded
you
there.
mentioned you showed that humorous case. We just had a case today there was a trauma, and on the it was a two view, and on the frontal view, both arms were down, and there was a subtle abnormality in the humerus, but on the lateral, only one arm was up, and and because the affected arm was down, you could see the fracture clear as day on it.
Yeah,
And the same thing is true on CT. If you ever see one arm up and one arm down, you have to explain it. And most of the time, it's
right.
the patient has a bad shoulder. But I've seen dislocations, fractures, tumors.
Yep,
Um, yep. So
it's a helpful clue.
the arm down sign.
Yeah.
All right. I think that is everyone. So great cases and great discussions. And we'll talk to you all next week.
Thanks.
Great. Thank
Bye, everyone.
you. Cheers,
See
Bye,
everyone.
y'all.
everyone. Bye bye.